Okay, thank you, Giorgio, for the presentation. Good morning, everybody. Let me thank Enzo Bonora for inviting me to deliver this speech. And actually, Giorgio was thinking right, because the title, I mean, I had to ask you the permission to change the title, because as I told Enzo when he invited me, is that I don't know much about metabolomics. So basically, we found a sort of compromise. The real title is this one, Prediction of All-Cause Mortality in Type 2 Diabetes Mellitus, and I promise you I will talk just a bit of metabolomics. So I have nothing to disclose, and let me spend the first 3-4 slides to remind you what we know about mortality rate in patients with Type 2 diabetes. Well, we know that the relative risk is very much increased, 80% increase in risk, which is a lot. And we know also, to put it in a practical way, if you are a diabetic person, 55 years old, you have the same probability of survival, or if you prefer, the same probability to die, that your non-diabetic counterpart who is 10 years older. So it's a great burden. And basically, it's the same also for women. We also know that most of the, that most of the risk, but not exclusively, is given by cardiovascular death. But also cancer and anything else that was in this study, neither cancer nor cardiovascular disease contribute to the overall increase of risk. But this slide tells us also something different that I want to share with you. That is that the cardiovascular disease, although being the primary cause of all-cause mortality in patients with diabetes, accounts for less than 50%. This means that other causes account for more than 50%. So no doubts that it is important to predict cardiovascular disease and cardiovascular mortality in patients with diabetes, but please, no doubts that it is also very important to predict all-cause mortality and not necessarily cardiovascular mortality. But here is the real problem. This is what we have been able to do in the last 20 years or so. Not that good, actually, because despite the fact that we have been able to reduce the risk of, the risk of mortality both in diabetic and non-diabetic individuals. In this case, we are talking about type 2 diabetic patients. I mean, the relative risk is still there. And it's the same if you look at cardiovascular death from cardiovascular disease. So basically, we are doing well as far as the general population is concerned. We are not doing well as far as type 2 diabetic patients is concerned. And the reason for this is probably explained by this slide here, which show that at least in the United States, but I'm sure that in Europe it's not going to be that different. If you take all individuals with diabetes who are attending a diabetes care unit, only a small or only some of them are well treated. And if you look at those who are well treated for, and if you look at those who are well treated for all these 4 variables, I mean, the percentage is very low. Approximately 1 out of 4 patients are well treated. So this is why we are not doing well. Our efforts are not infinite. I mean, we have a lot of, many ways to address this point. But the problem, the issue that I want to share with you is that we need to predict high-risk individuals because we cannot treat all of them. So basically, if we want to maximize effectiveness and minimize cost, and we have to tailor follow-up and treatment to those patients who are most at high risk. And these need well-performing prediction models. And these models are better to be also parsimonious, especially if they have to be used in context with limited resources. So what we need is being able to predict who is at high risk to die. And we tried to give our own contribution in the last years, trying to set up prediction model that can be usable in the daily clinical work. Some years ago, we developed and validated a predictive model of all-cause mortality in patients with type 2 diabetes. I mean, the model performs well, but at that time, it was able to predict with a very short time horizon, only 2 years. And I'm sure that many clinicians in this room would agree that, I mean, it's a too short time horizon to be really useful. Then we kept working on it, and we just published a sort of extension of that model that we now call M-Force. And I will show you some features of M-Force. But now the time horizon of the model is 6 years, which is much better for clinical purposes. So M-Force is an accurate prediction model of all-cause mortality in patients with type 2 diabetes. Is well calibrated. It has been validated in 2 independent samples, not just 1. It's parsimonious because you need only 9 very common variables to use M-Force, and the variables are listed here. As you can see, very common variable: age, antihypertension treatment, diastolic blood pressure, insulin treatment, and so on. Very easy stuff. It's easy to use. You don't need more than 1 or 2 minutes to have the answer regarding the risk of mortality of your patient. And it's freely available on the web, and we are particularly proud about this aspect. And you can find it for free either in the website of our institution or in the website of the Italian Society of Diabetes. So you can go there, and in 1 or 2 minutes, you can have the answer that you need for your patient. This is the way we developed the model. I mean, we developed this model by including in a multivariate Cox model 15 different variables until they were able to improve this value, which is the net reclassification improvement. So you go down. You put the first variable in the empty model, and then you go down, down, down. When you get here, after you had the 9th variable, which was triglyceride, then when you try to add the 10th one, I mean, you don't get any significant improvement, and then you stop here. This is how the model was built, and these are the p-value for improvement of net reclassification improvement, as I said. So basically, let's look at some features of this model. It's quite robust, and it's quite reproducible in 3 different Italian samples. You see the statistic here. This is the pooled analysis on more than 3,000 individuals, almost 800 events. And of course, there is no heterogeneity across the 3 samples. So far, so good. And this is some post-hoc analysis. So especially for young people, I recommend you to take this data with a lot of caution, because post-hoc analysis are very interesting, can be very suggestive of something going on. But I mean, they need a lot of caution. But I mean, what we see here is that you don't need actually the information on myocardial infarction and stroke, because when you have it or when you don't have it, the statistics of the model doesn't change at all. So basically, the model is independent of previous cardiovascular events, whereas in contrast, at least in our hands, it seems that the model performs better in individuals with a good A1C. Of course, these data are just suggestive and needs to be replicated in additional samples. And one more thing that I can tell you is that we were good enough to stratify patients in 4 groups, from low risk to high risk, with low intermediate risk and high intermediate risk being, of course, in the middle. And these are very robust. However, I want to let you notice that, at least for the high risk, we were able to robustly indicate this threshold, but nothing better. I am sure you agree that if I have 34% risk of mortality in the next 6 years, or if I have 84% risk of mortality in the next 6 years, it is really very, very, very different. However, with this model, we were not able to find the threshold for very high-risk patients. This means that probably the model can be improved, and you will see that this is in fact the case, by being able to reclassify very high-risk patients. But I will come back to this later. Another problem that we found with our model is that it's not usable in a different set. We try to replicate our data in the ACCORD trial. I'm sure that all of you know the ACCORD trial. Basically the same number of individuals, of course less events. And unfortunately, although ENFORCE is able to significantly predict all-cause mortality in the ACCORD trial, I mean, the prediction performance was much worse than in the Italian cohort, so that, I mean, the p-value is very, very high. So, I mean, if we want to summarize a little bit what I've said up to now, we have a model. The model, as I said, is accurate, calibrated, validated, parsimonious, easy, and free. However, we have also some problems. We have limitations. The first one is that it might be a transportability in different clinical setting issues. We are not sure about that. But what we are sure about is that if we improve our C-statistics, this problem will just disappear. So we need to improve C-statistics in this model. And the second thing is that, as I showed you a couple of slides before, I mean, we have a sort of overestimation of the risk of mortality, especially in patients which are supposed to be at high risk. To address this limitation, what we need is to improve reclassification of individuals which are presumably at high risk. And I will show you how we can do that. So, in the last few years, our effort has been to try improve ENFORCE performances by the identification of novel informative markers to be added on top of the model. Which markers? Okay, basically we have been interested in inflammatory markers, and I will show you some data about this. But very recently, we got involved also in a marker from metabolomic studies. And this is the reason why Enzo asked me to be here today. I mean, I have very, very, very preliminary data that I'm going to show you. I'm happy to do that, but please don't forget they are very preliminary. In the meanwhile that we were working 2 months ago on this project, 2 months ago, a beautiful paper came out in Nature Communication, addressing 44,000 individuals from the general population. And this paper, in this study, 14 different metabolites popped up as being able to be associated very strongly with all-cause mortality. And what is interesting in this paper is that if you use these 40 metabolomic biomarkers, consider in a combined fashion, you get an area under the curve which overperform that of conventional risk factor. So very encouraging results. I don't really know if the same markers are going to work also in patients with type 2 diabetes. Probably yes, but we don't know. And I don't even know if there are specific markers that will be able to sign the risk of mortality only in diabetic patients. So sort of, diabetes-specific marker. I will show you the very small pilot study we just carried out. This is on a different platform. We tested 180 metabolites in association with all-cause mortality in this small sample and not too many events, as you see here. And 19 were statistically significantly associated with all-cause mortality. Only 4 of them survived the false discovery rate adjustment, to account for the multiple testing. So basically, encouraging results. None of these 4 was in the list of the 14 that I previously showed you. Then probably it is true that we do have some metabolomic markers which are specific for diabetes. But I mean, there is a lot of work to do, and I hope that if Enzo will invite me in 3 years, I can come here with very solid and robust data. But actually, the last 2 years have been spent by investigating inflammatory proteins. And I will show you also, in this case, some preliminary data, a little less preliminary that have not been published yet. So just to remind you that inflammation recognizes both acute phase and low-grade chronic inflammation. Some of these proteins from acute phase are also playing a role in the low-grade inflammation. And cytokines are very important in low-grade inflammation. And these are 5 of the many proteins that you can find in acute phase inflammation. We have data on cytokines that I will not go into show you, and we have data on C-reactive protein, serum amyloid component P, also known as SAP, that I'm going to show you. So basically, why these 2 proteins? You all know C-reactive protein is a well-known molecule involved in inflammation, co-localized with complement deposits in human atherosclerotic lesions, binds to oxidized LDL, and mediates their uptake by macrophages, and is an established marker of cardiovascular disease and all-cause mortality in several clinical settings, although its role in improving established prediction model is debated. And don't forget, we are interested in trying to improve established prediction model. SAP was found too in human atherosclerotic plaque, and similar to CRP binds to oxidized LDL. However, rather than increasing macrophage uptake, it decreased macrophage uptake. No much is known on the role of SAP on cardiovascular disease and mortality rate. And most importantly, there are data in the literature that I show you in this slide that pushed us to think about a possible combined effect of CRP and SAP together. Why? Why this? Because the 2 molecules share structural and biological features. They are encoded by 2 genes which are both located on the same chromosome and which are very close one to each other. They cluster in the same pathway, suggesting a coordinated regulation of their activation and their effect. And finally, I would say, and very importantly, SAP and CRP interact in a calcium-dependent manner in vitro. So this interaction might have functional implication. Because of all of this, we decided to test the role of CRP and SAP on all-cause mortality in a combined fashion, and then to see whether or not their combined effect can be useful in improving the mFORCE model. These are the 4 samples we used for this study. Nothing really strange. I mean, age of recruitment around 60 or 65 years old. All these, as I want to remind you, these are patients with type 2 diabetes duration of 10 or more years, BMI around 30, a lot of treatments going on, and an event rate of all-cause mortality ranging from 1.8 to 2.8 per 100 person year. So these are basically the results of association. In a model where when both proteins are present, you see a clear association, positive association for CRP, and this is the pooled analysis. And you see also a clear inverse association for SAP, and this is the pooled analysis. So CRP increased the risk of mortality, 54% increase the risk for one standard deviation increase, and SAP decreased, 20% decrease for one standard deviation increase on SAP. And this association is definitely, it survives in a multivariate model, so it's independent from many other well-established marker of all-cause mortality. This is the multiple variable study, which demonstrate that both association, that of CRP and SAP, are independent association. But the most important thing that we observed by looking at our data was that the 2 proteins were interacting each other. In other words, the protective effect of SAP was visible only in those patients with a higher level of CRP. And to show you this phenomenon in I hope, in a simpler way, we stratified our subjects in 4 subgroups: CRP more or less than 2, that you all know is a threshold which is used in the clinic work, and low SAP, arbitrarily defined as SAP in tertile 1, or high SAP, arbitrarily defined as SAP in tertiles 2 and 3. And these are the curves that we get. These are patients with low CRP. These are patients with high CRP. And as expected, these patients have a much higher mortality risk than these patients. But then what happened with SAP? This is high SAP or low SAP in individuals with less than 2 milligrams per liter of CRP. Basically, not much difference. And in fact, as compared to this group, the hazard ratio here is virtually 1 or close to 1, not significant. This is not what happens in individuals with CRP more than 2, because these two hazard ratios are very different. So if you are a diabetic person, a type 2 diabetic patient, and you have high CRP, you better have high SAP, because if you have low SAP, you are going to have 3.1 times more probability to die as compared to the first group. And this is clearly confirmed by a significant interaction when you test the interaction between strata of CRP and strata of SAP. So, encouraged by all these results, we said, okay, so the two proteins really do associate with all-cause mortality. They are able to discriminate a little bit, at least among people with a high CRP. Let's see what happened when we had these molecules, this data on mFORCE, on top of mFORCE. And this is what the results that we got. This is mFORCE C-statistic in this specific subgroup of individuals, 0.75, still very good. This is what happens when we had CRP on top of mFORCE, a little better, significantly better. You know that C-statistic cannot be moved very much by one single marker. And this is what happens when you had SAP, nothing. Sorry about that. Okay. Okay. This is tricky, actually. Just nothing. And this is what happens when we had, on top of mFORCE, both CRP and SAP, a further improvement, which is significant. Let's give a look to percent relative IDI. You get a good improvement, although barely significant, when you had CRP on top of mFORCE. Nothing, again, when you had SAP by itself, and a very good improvement when you had both CRP and SAP. I want to remind the people in this audience that the American College of Cardiology and the American Heart Association use the threshold of 6% of IDI to decide if a novel marker can be added on top of established prediction models. So we are clearly well above that threshold. And finally, let's give a look to the reclassification that we were very much interested on. This is reclassification, very good reclassification when you had CRP on top of mFORCE. Again, nothing when you had SAP. And a very good reclassification when you had both CRP and SAP. If you give a look how you have been able to reclassify so well what mFORCE by itself was able to give, everything comes from the ability to reclassify non-events. So basically these were individuals that were not going to die, that we were making a mistake, pointing them as at high risk, so sort of false positive results. And I want to remind you that what I was talking about here, it was exactly the same thing. I mean, we have an overestimation of risk, especially in high-risk patients. We need of improving reclassification. And actually, this is what we have done. So very useful, the addition of CRP and SAP on top of mFORCE to reclassify high-risk individuals. So, as I said, we are working on this. I mean, of course, I showed you just few data, very preliminary data, but we are working hardly on this, and are really interested in identifying novel informative markers to be added on top of the model. And let me summarize what I said in these 20 minutes or 25 minutes or so. So we have ENFORCE, which is a well-performing, parsimonious, easy-to-use, and freely available prediction model of all-cause mortality in patients with type 2 diabetes. I hope you agree that it stands already as a service to the whole diabetes community, both patients, families, and clinicians who take care of these patients. You can go on the web and you can use it for free. Our aim is to further improve ENFORCE by adding new biomarkers, and we anticipate or we hope that the implementation right now and the improvement of ENFORCE in the future will enable more aggressive, costly, and burdensome preventive strategies to be targeted to high-risk patients, thus maximizing effectiveness and minimizing cost, which is, if you allow me to say, approaching the dream of precision medicine. Before to conclude, let me thank the Italian Ministry of Health, the European Association for the Study of Diabetes, and the Italian Society of Diabetes for providing us support to do this research. I want also to thank patients and family for allowing us to perform this study. And finally, I want to thank Massimiliano Copetti, Salvatore De Cosmo, and Andrea Fontana for the development and validation of the ENFORCE model, and Claudia Menzaghi and Maria Giovanna Scarale, who is in the audience, for hunting novel biomarkers to improve the ENFORCE model. And I thank you very much for your attention.
Thank you, Enzo, for the presentation, which is now open for discussion. Professor Renzo Cordera, in the first row.
Posso avere un po' d'acqua?
Certo.
Ce l'hai dietro, ce l'hai dietro.
While you're drinking some water, congratulations for this presentation that is quite difficult to follow for me. I have a couple of questions. First of all, I noticed that duration of disease and glucose control come out in and out in this model. I'm not sure which is the role, because I have the impression that you are saying that glucose control is not so important. And second, this new data can support the idea to taking something like aspirin as or no?
Renzo, thank you for the question. I'm not sure I understood exactly what you are asking for. I mean, I'm sure I understood what you say with the second question, and the answer is nothing to do with aspirin. I mean, if people have to get aspirin, I will get aspirin, and that's it. Don't stop. Say it again?
More people.
Yeah, no. I mean, I don't know, actually. I don't know. I mean, I don't think we can derive any conclusion from this data. The first question was about glucose control. Duration of disease. No, duration of disease, I can show you, if I can go back, I can show you. Let's say like this. Okay. This one here? No?
Potete rimetterla la presentazione?
Questo. Oh, okay. Right. I found it. Yeah. Okay. Sorry about that. Almost there. Okay. So basically, as you see, duration of disease was not in the 9 variables that we were able to pick up because able to improve the net reclassification improvement. So duration of disease is not there. Then if you ask me what about duration of disease, what I can tell you is that when you have in the same model age and duration of disease, age is much more stronger, at least in our hands. But I mean, age, whereas age was the first one to get it in the empty model, as you can see down here, duration of disease was not picked up by our selection model. Neither. And of course we had it. Hemoglobin A1C and duration of disease was among the 16 very common clinical variables we start with, but they were not selected.
If I can add, Enzo.
Sorry.
This is an all-cause mortality prediction model.
Right.
It may be different a little bit if you make a prediction of cardiovascular disease. Some of these variables can jump out and others jump in.
Definitely. It is definitely a possibility. I can say just nothing about cardiovascular mortality because we didn't perform any study, but I mean, the possibility is definitely a plausible one. Yeah.
Marco?
So brilliant as usual. I was thinking about the ACCORD data that is not fitting to the enforced model. Have you investigated which variables are not working in that population compared to the Italian one? And have you tried different variables to fit into the ACCORD population?
Okay, Marco. So basically, what I have to tell you is that, but then I want to speculate a bit. What I have to tell you is that if you are trying to validate a model, you have to use it as it is. You cannot split it in different variables. This is something that would be methodologically not correct. So what you do, you get the model that you develop and you validate it. You want to validate in another clinical setting, you have to use the model as it is. I mean, you cannot make any shuffling and stuff like that. But I want to comment on the reason of this difference. Let's go there. Is this one here, okay? Of course, I don't know the reason for this partial inconsistency. But what I can tell you is that in the last 2 years, John Yudkin and co-workers developed a wonderful prediction model of many chronic diabetic complications, including, if you want to say that is a complication, all-cause mortality. And basically, I didn't show the data, their model performs exactly like our model in our samples. Their model performed exactly like our model in the ACCORD trial. But what is very important for us is that they developed the model in a trial sample and they validated the model in a real-life clinical setting. And also in their hands, prediction in the real-life clinical setting was much better than that observed in the trial. So this might be a general phenomenon, and the explanation may be complicated, or we can hypothesize whatever we like to, but I mean, can be a generalized phenomenon because a different model in different hands, in different geographical region and genetic and environmental background, same results. If you move from real life to trial, the performance goes down. So this is what I can tell you, but no more than that.
Please.
Stand up and
okay. Give the names just to know where you come
Alberto
from.
Scicali from Catania. Dear Professor, thank you so much for presentation. Just one question. In this context, CRP may be a good biomarker to predict, to better predict risk of mortality. 2 years ago, the CIRC study showed that the use of methotrexate to reduce CRP failed to improve cardiovascular mortality. So, do you think that CRP may be only a biomarker or also a biotarget?
I mean, in your question, you find a possible answer, which is, a possible biomarker. I have doubts about biotarget, also because I'm sure you are aware of studies Mendelian randomization studies showing that CRP by itself doesn't cause cardiovascular disease. So for all these studies, the impression that I have is that it's a good marker, very good marker. We have to use as a marker, but not as a target. Did I answer your question? Okay.
Please.
Peter Villay. And then Morier.
Hello, hi, I'm Peter Villait. So thank you very much for your talk. It was really fascinating. I've also been thinking about the possible explanation for this differences in the performance between the Italian cohort and the core trial. And so I'm coming from cardiovascular research, and we're doing lots of work into risk prediction as well. So one thought that I had, and I know so in the cardiovascular field that's done quite often, is that the baseline risk of your in the two populations might be different. So the inclusion and exclusion criteria might be different. Also, there's a lot of variability between the countries. So I know for the European Society of Cardiology for the score, but also for other risk prediction models, often it's just that only thing, so the baseline risk that's adapted, and maybe that would be a strategy to kind of like find out whether that's the cause or not. And then my other question related to the sequence of how you evaluated the individual predictors. So it was quite surprising that sex was not part of that risk prediction model. So was there any difference when you entered, or did you try to enter sex as a variable early on? So step 1, step 2, after age, or something like that? Did it make any difference?
Okay.
Any difference?
Okay. Okay, let me start with the second one, because it's clear that I have not been clear. I cannot decide which one goes first and second. I mean, the model decides which one is the first one, which one is the second one, and sex was the 10th one, and I cannot move sex from there. So basically, this is something that I cannot try. Have I been clear? I mean, it's the model which performs with all 16 variables together, and every time, choose the one who is better to improve net reclassification, improvements. Sorry for the improvement, okay? So basically, it's not my choice, okay? And this is the second question. The first one is very smart. We thought, we know why. Because the risk at baseline is different, but unfortunately, we were wrong. And I will show you the data here, because the Accord has an incidence rate which is similar to what we found in this sample here. And basically, so of course this doesn't say anything for sure, but I don't think that the major problem of the difference we observed between Italian samples, real life samples, and the trial samples come from the different baseline risk of these two different samples. Okay? Okay.
Thanks, Enzo, for a very nice presentation. I'm Morier from Padova. And I would like to go back to the interaction between CRP and SAP. And as you were saying, and also as Roberto was saying, probably CRP is not a causal factor, and we are seeing this from Mendelian randomization studies. However, I would like to ask you if we should maybe reconsider also the results from Mendelian randomization studies based on your preliminary results. In Mendelian randomization studies, we use genetic variants associated with CRP in this case to evaluate if CRP may be causally related to the outcome or overall mortality. But if SAP and CRP are close by in the gene region, it is possible to think that the Mendelian randomization studies that has led us to the conclusion that CRP is not causal may be influenced also by the levels of SAP. And so that's the question.
Yeah, I mean, it's a possibility that I cannot exclude. Actually, what I would like to do, but you know what I'm talking about, and this means that I will never be able to do that, is run a Mendelian randomization also, not only with CRP, but CRP and SAP together, and SNPs giving information on SAP. That would be great to me, according to this data. But I mean, your hypothesis is a reasonable one, but as you can understand, I can just say that I agree with the hypothesis, but I have no data to solve the problem.
Other questions or comments from the audience?
I have another question/comments. The prediction are important. Prediction of all-cause mortality, I think, is more important for insurance companies than for clinicians, because if you want to change the natural history of that person, of course. And it is different, probably, the intervention you can plan if you can predict cardiovascular mortality or cancer mortality or infective disease mortality or other kind of mortalities, trying to correct risk factors if it is possible to change some of them. So I think it would be more important to go into more detailed prediction about the true cause of mortality with this model. So, I mean, cancer or probably cardiovascular and so on, because you can identify individuals with higher risk, and in those individuals you can, for example, have a more strict control of blood pressure or LDL cholesterol in case of cardiovascular mortality or other risk factor related to cancer mortality. Do you think that's a correct way of thinking?
Yeah, no, it's a right way of thinking, of course, and I would love to be able to do that. Okay, if you allow me, I mean, I am no longer a scientist and I am a clinician. Sometimes I use both the model from the American College of Cardiology and my model, and the risk prediction is totally different. So in that case, as a clinician, I drive crazy because I don't know what to do. I mean, okay, so I understand your point. I agree with your point, but let me be nice. I hope that the young people in the audience will do that, because it's going to be very difficult. You need huge sample sites, really huge sample sites, and with cause of mortality, and so which it's very difficult to record in a robust way, which cause of mortality recorded very well. So I don't think I have time to do that, but I will start doing that.
I have just a provocative comment. I guess that no people was taking GLP-1 or SGLT2 inhibitors, because probably they are included in the model by virtue of the effect on the mortality of both drugs. But this is just a provocative comment. My comment is instead regarding the SAP. Obviously, you have SAP, but SAP is not so common in our laboratory, and it's quite difficult to measure in a routine. Have you tried to use albumin? Because albumin is very correlated with, inversely correlated with inflammation, both as a biological model, because, for instance, albumin is reduced by cytokines, and also because albumin is protective in terms of cardiovascular events and probably also mortality. Have you tried to do this? Because albumin is more easy to obtain in our routine lab.
No, I have no data. I think it's a good idea. We can go back to the data and look if anything pops up. Giorgio, what I would say right now is more than adding a single marker, which is okay, but more than adding a single marker, what I would love to do right now, and we are asking for money as usual, is to have a comprehensive approach with tens, if not hundreds, of inflammatory biomarkers to be used all together. I'm sure you are aware of the paper published by the Jocelyn Group on diabetic kidney disease. They use 180, something like that, inflammatory markers, and they came up with a signature, specific signature, which is able to sign diabetic kidney disease. Okay, that is an intelligent approach and a good approach. Of course, you need money, because it's going to cost probably 250 euros per person if you want to run a sort of multi-marker inflammatory platform. But, I mean, this is the approach that we should use, I mean, possibly. So albumin is okay, but I will not do albumin by itself and then another one and then another one. I will try to do as much as we can once.
Okay. Can I add just a comment on this? Because this approach of using multi-markers, of course, is intriguing. And it is even more intriguing if the markers are intercorrelated. Because the more are these biomarkers, new novel biomarkers, correlated each other, the less is the gain you get in statistics.
Yeah.
So ideally, one should try to find biomarkers who describe different pathophysiological phenomena to put into the model.
Yeah. I agree, and in fact, I didn't have time to show all this data, but we right now are working on as I think I said some words on that. We are working on two different sides of inflammation. We are working on a group of cytokines we are interested on that belong to a pathway that we describe as being a resisting pathway. There are 5 cytokines, all interrelated and all giving information on a resisting biological pathway, and pentraxins because they belong to acute phase. But I mean, the idea is correct. The problem is how long can you do these studies without some other one who will, publish something before you? I mean, the problem is always that. Then a comprehensive approach, I am sure, is less, fascinating. But it's very likely to be more practical if you have money.
Okay. The last question by Renzo, and then we have to move.
Your second or third slide.
Second slide?
Or third slide, when you show the reduction in mortality in non-diabetics and diabetics. Are you sure that the result is not depending on the starting value? In other words, the relative reduction in diabetes and non-diabetes is the same.
So you say this one here?
Yeah, you see a reduction in the...
Yeah, I mean, Renzo, both curves are going down, so this is good. But there is no doubt that this curve is not doing better than this one. If any, this one is better than this one. So the difference that you have in 98, 99 is going to be at least the same, if not increased in 2014. So the relative risk of diabetic patients is still there. We are not doing any better in patients with diabetes, with type 2 diabetes in this case.
But in absolute terms, yes.
Yeah. Yeah, but I mean, when you have a patient, I mean, he's an absolute patient. I mean, clinic, of course, but the number of individuals who are dying, of course, is reduced, very much reduced. But the difference as compared to non-diabetic counterparts is not reduced. It's still approximately twice as much.
But for cardiovascular disease?
Yeah, for cardiovascular disease, it seems to be similar, but probably we have something better. I'm not sure. I didn't calculate if this difference here is larger than this one, but, I mean, this seems to be parallel, and probably we are doing the same thing both in non-diabetic controls and in type 2 diabetic patients. I mean, I would use this curve not for the single point, but just as a general phenomenon, no? There is still a lot of difference. The take-home message is that after 15 years, there is still a lot of difference between type 2 diabetic patients and non-diabetic counterparts. There is no doubts about that. Okay.